It is my great pleasure to introduce to you Dr. Lindsay Hampson. Dr. Hampson is an associate professor of urology and the Frank Hinman Jr. Endowed Professor in Urologic Education. She's also the Associate Chair of Education, the Residency Program Director, and the Associate Fellowship Program Director for the GERS Fellowship at UCSF. And I'm just going to take a moment to highlight just what an amazing urologist she is. Dr. Hampson did her undergraduate training at Duke University, where she graduated with a degree in bioethics. She then did a 2-year research fellowship at the NIH Department of Clinical Bioethics, and then went on to do her medical school training at the University of Michigan on a full academic scholarship as a Dean Scholar. She then completed her urology residency at UCSF, where she also did a research fellowship at the Philip Lee Institute for Health Policy Studies and earned a certificate in advanced training in clinical research. She then completed a fellowship in genital urinary reconstruction and trauma at the University of Washington. And in 2016, she was recruited back to the faculty at UCSF, where she currently serves as the co-director of the UCSF Lifetime Congenital Urology Program, and as I mentioned before, the Associate Chair in Education, Residency Program Director, and Associate Fellowship Program Director for the GERS Fellowship. She has received numerous awards for her mentorship and teaching, including the Excellence in Innovation in Graduate Medical Education Award, the UCSF Explore Mentor Award, the UCSF Department of Urology Carroll Mentorship Award, the Young Urologist of the Year Award by the AUA, and she has been funded by multiple NIH awards, including a K Award, an RO3 Award, and a Doris Tube Charitable Foundation grant. Today, she'll be speaking about understanding patient perspectives, advancing individualized decision-making and tailored treatment in reconstructive urology. Please join me in welcoming Dr. Hampson.
Thank you so much for the introduction, and it's a pleasure to be here. I don't think Michael ended up making it. Mike Leitman was a fellow at UCSF when I was a chief resident, and I think he's sick, so I am hoping to connect with him by Zoom today when I'm here. But, you know, I had asked around before I came to see if anybody had any scandalous stories that I could share about him. And if you know Mike, then you know that all the stories were way too racy to share. So, you know, instead we just remember him as a very kind and humble individual. Sorry, no problem. All right, trying this again. See if this works. All good now? Okay, great. So while I'm talking about reconstructive urology today, I am going to try to make this really generalized so that there's something in it for everyone. So hopefully everybody has something to kind of take away from today's talk. And these are my disclosures. I think in reconstructive urology, it's such an important concept to talk about decision-making, because so much of reconstructive urology is about quality of life. And these are decisions that people, you know, have a choice of whether they make them or not in terms of proceeding with treatment. So taking into account, you know, patients' goals and values, understanding what patients want to make treatment individualized, helping patients make treatment decisions that align with those goals and values is really important. But this, again, applies outside of reconstructive urology. You know, every part of urology can benefit from improving decision-making. So I'm going to focus this talk on giving you some of the data behind all of this kind of thought process on decision-making by focusing on stress urinary incontinence in men. But again, you know, widely applicable, but this is something that I've done a lot of work in and thought a lot about. So I think first, you know, in terms of where we are with decision-making, we know there's a disconnect between what surgeons think patients want and what patients actually want. And this is an older study now that was done by Dr. Nitti, but I really like it because it really showcases this well. They interviewed patients and they basically said, okay, the surgeon is going to recommend for you in your case, Should you get a sling for your incontinence? Should you get a sphincter? Or it doesn't matter, you'd be a good candidate for both. And they saw what the patient, would want to do in that case. So when sling was recommended, everybody chose sling. When given a choice, 92% of people chose sling. Probably not surprising, right? Avoiding a lot of the mechanics of having a device. When sphincter was recommended, they said, you are not a good candidate for sling. We think you should get a sphincter. 25% still wanted to go with a sling. So there's clearly some disconnect between, what surgeons understand about patients' goals and how people are making treatment decisions. And, we did a little pilot study looking at what factors are important to patients when they're making treatment decisions about stress incontinence. And what I wanted to just highlight was the fact that, the urologist was actually a big influence to people in terms of what decisions they're making. So what the urologist recommends actually carries a lot of weight. And for that reason, I think we as urologists have to be really careful and thoughtful about our treatment recommendations because they do hold a lot of sway for patients. We also looked at this in a cohort of about 130 people at UCSF in the San Francisco VA. And we asked people who had undergone treatment decisions for stress incontinence, meaning they had come in for consultation and they had either undergone surgery or decided they wanted to just avoid surgery and proceed with conservative management. And we asked them, looking back, do you have any regret about your decision? And we found that a little over 1 in 5 had moderate to severe decisional regret. And interestingly, actually, what I was not anticipating to find was that those people who hadn't pursued surgery actually had much higher levels of regret. And so clearly, we're not meeting the mark for our patients in terms of their eventual satisfaction with their treatment outcomes. And when we looked at this kind of more carefully and looked at the factors that were contributing this, it wasn't things that you might have thought would be contributors, like did somebody have a complication after surgery or their age or their comorbidities? What it was associated with was depression, their current incontinence scores, and the level of shared decision-making that they felt they had when they made the treatment choice. And, I think that shared decision-making piece is important because that's something that we as urologists, as surgeons who are counseling our patients can actually have an impact on. So I want to talk about kind of 3 concepts that I think are really important in terms of surgical decision-making and how we can improve it. One is thinking about the individual patient and how we take them into account. The next is how we focus our discussion of risks and benefits so that we're really focusing on something that patients care about and not necessarily what we as surgeons care about. And then also how do we understand patients' values and preferences? Because if we want to make treatment recommendations that align, then we have to understand what those values and preferences are. And I think this is a really useful theoretical model. This is a framework developed by Louise Walter, who's a wonderful geriatrics researcher at UCSF. She's been a big mentor of mine. And she did a lot of work early in her career looking at PSA and screening and prostate cancer and veterans. And I think, she's used this model in various disease processes, but it's one that really, I think, captures the kind of concepts nicely. You're thinking about these kind of 3 buckets of patient health and prognosis, the benefits and harms of treatment, and patients' values and preferences. And you're understanding that each of those concepts is really important when you're thinking about making goal concordant decisions, individualized decisions for patients. So we're going to kind of go through this this morning and talk about each of these aspects, and I'll give you a little bit along the way. I am going to throw in some little other tidbits. As I said, I want there to be something for everyone. So we're going to talk a little bit about mortality and how to estimate it. I think this is really useful for residents, especially. Frailty, what is it? How do you measure it? Why do we care? I'll mention qualitative methodology. I think that's something that people have less experience with, but it can be really powerful in this work. And then I'll talk about an analytic technique called conjoint analysis, which I think is a really interesting tool. So first, let's talk about patient health and prognosis. And, why do we care about this? Why does it matter? I think, patient health and prognosis certainly adds to the complexity of patient decision-making. So we know that plays a role. And we also know that it can impact outcomes. And so when you're thinking about treatment recommendations, obviously this is going to come into play. looking at our stress incontinence population, we know that this is, these male stress incontinence patients, vast majority are post-prostatectomy incontinence. We know that these are surgeries that are often performed in older men. And so we actually looked at this cohort from the San Francisco VA and UCSF, and we found relatively high rates of comorbidity, of limited life expectancy, functional dependence, and frailty. And I think these are really important aspects of patient health to take into account. So if you look at this graph, I think you can see nearly 80% of people had a Charlson comorbidity index of 4 or more, which is considered severe morbidity. So these are sick patients that we're operating on. Specifically looking at stress incontinence, comorbidity is really important to take into account, maybe not in the ways that you might think. Ben Breyer at UCSF did a nice NISQIF study a couple of years ago looking at sling and sphincter surgeries and found that actually what predicted complications wasn't the Charlson comorbidity index or even age, but it was BMI. So there, maybe you might not think of, you may think comorbidities themselves as the Charlson comorbidity index are really the drivers, but it doesn't look like that's the case in incontinence. And I think that's something important to notice because in your own surgeries, you have to think about what are the specific, drivers of complications. In incontinence surgery, a huge driver is the urethra. We know that if people have had radiation, if they've had a prior urethroplasty, or if they've had a prior, incontinence surgery, they have much higher failure rates. And so this is another nice, Kaplan-Meier curve of showing the compromised urethra, which is, the line that's darker, that's obviously having a lot higher failure rates, and then the, uncompromised urethra is up top. So you can see those hazard ratios listed there. You have a much higher risk of having a complication from these surgeries if you've had radiation or urethroplasty in the past. So life expectancy is something that's also important when you're thinking about counseling. And in our cohort, 75% of people had a greater than 50% 10-year mortality risk. So these are, again, they're sick patients and they have limited life expectancy. And so I think it's important to understand how to calculate that life expectancy and then think about how to take it into account and how it matters. So I'm going to diverge a little bit here to talk about life expectancy, and I should go back. So this is the website that I think is wonderful, eprognosis.ucsf.edu. It takes you to a lot of calculators, including this life expectancy calculator. So you can see on the left, when you go, I just took screenshots. This is these, if you click prognostic calculators, it allows you to pick what kind of calculator you want. And then you can really pick who your patient is. So what are you trying to estimate? Where is the patient located? Are they in a nursing home? Are they in the hospital? Are they an outpatient? What your time frame is? Are you looking at 1 year mortality or longer? And this is an example on the left. This is called the Lee-Schoenberg index. They're basically the Lee index and the Schoenberg index that are put together but give you different scores. And this is actually very easy to fill out. So if you are, a resident in clinic and you're counseling somebody about, evaluation of their PSA and thinking about prostate cancer screening, this is a very easy tool to use. It takes about 3 minutes to fill out this survey. You can do it, and I do it with the patient. I just say, okay, we're going to pull this up. We're going to look at what your life expectancy is so that we can understand how we, make these decisions. And together we go through and fill these things out. None of them are hard. All of them, the patients or the chart is going to have the information you need. And then you get this nice score. So this is the Lee index that I'm showing you. Again, it'll show you also the Schoenberg index, which are quite similar. But you can see, I picked over on the left when I filled this out to just take screenshots. I picked everything relatively healthy, and you can see it came up with 6 points. You see the risk of 5-year mortality, the risk of 10-year mortality, and then the calculated life expectancy. So this is something that can be really easy for people to understand. And I think for you as a, physician, as a surgeon who's counseling somebody, obviously something important for you to take into account depending on what surgery it is that you're doing or what kind of decisions you're making. I think when it comes to quality of life, the life expectancy may not matter as much, right? Because we're really thinking about how can we improve whatever years people have left. And I've certainly have, I've put a sphincter her in a 90-year-old who said, I know I may not have very many years left, but I want them to be dry. And I think we would all understand that. So you have to kind of understand the context of life expectancy, but it can be helpful for people when they're making decisions, because if they're trying to decide, do I want a surgery that I may need another surgery for, or do I want a surgery that's less likely to work and then I may have to get another one? These are things that may help them make their decisions. And my own bias and perspective is that, we really may undertreat people based on their age and life expectancy. And so I don't think life expectancy should be a driver for treatment, but helping people to understand the right treatment for them. And then also in this kind of health context, I think frailty is really important. And this is something that's been talked about more recently. It's been termed the fifth vital sign. We found in our own cohort, a little over 1 in 5 individuals were frail or pre-frail. So this is definitely something that's prevalent. And what is frailty? So it's a measure of physiologic vulnerability. And typically how you think about it is it's an impact to multiple organ systems that basically increases people's risk of disability. And this is from an article from Freed, who's really done a lot of publishing on frailty, where he shows this kind of, overlap of frailty and comorbidity and disability. But importantly, these things do not equate each other. So frailty is not comorbidity, and it's distinct from disability as well, although there is some overlap there. So how do you measure frailty? There are lots of tools. Some of these are tools that are more clinically focused, some are more research focused. And the one we use in our clinic is quite easy. Every single patient that comes into our clinic gets this done. So we use this timed up and go called the TUG test. And somebody starts in a seated position. We do this when we're getting their vitals. So the MAs do this when they're rooming patients. That we start the clock, and when we do, they stand up, they walk 10 feet to a line on the floor, they turn around, they come back, and they sit down, and the clock stops. If they can do that in 10 seconds or less, they're not frail. If it's more than that, then they're pre-frail, 11 to 14 seconds, and then frail greater than 15 seconds. So this is something very easy, but gives you a very good marker of, the kind of overall frailty of the patients. And this is something that probably correlates somewhat with your own kind of observations, right? You see your patients in clinic, when you go in, who might fall into the frail category and who may not. And Anne Susskind has done a lot of work in frailty, and she looked at our own population of over 1,000 of our benign urology patients and just said, okay, of our patients, who's frail? And you can see this graph down here, this stacked bar graph, where you see the kind of levels of frailty. So starting at age 65 to 70, and you could see, about 30% rates of frail or pre-frail individuals. And then you see once you get up to, over 85, just super high, 90% of people with frailty. So obviously it correlates with age, but you can see that there's a lot of frailty even at these kind of younger, older age groups. So why do we care about frailty? In general, there's lots of studies that show that frailty correlates with worse outcomes. So this is, again, a study by Freed that's a kind of seminal study that shows that frailty correlates with worse overall survival. But there's plenty of other studies that show that frailty correlates with other bad outcomes in general. But in urology in particular, we know that frailty is also an important predictor of complications. So again, this is work by Anne Susskind, who, looked at the urologic complications within kind of routine common urologic procedures, and found that frailty is a predictor of complications, and in fact, regardless of age. So if you look at that 40 to 50 group, you see that, if they have 2 or more frailty items in the scale that she was using, you have a much higher incidence of complications. And these are 2 really nice studies that she also did that show that frailty is associated with complications across common urologic surgeries. So, I guarantee that whatever you do, you're going to find your surgery up there, prostatectomy, TURPs, URS, lap nephrectomies. And, you see that almost every procedure we do, frailty is associated with complications. And then importantly, and a lot of people, care about this both because they care about patients, but they also care about, what happens with where your patients go afterwards in terms of hospital resources and how you're evaluated. Frailty also is associated with a discharge to a SNF after surgery. So these are really important things. And if if you're assessing frailty in your patients and you're talking about frailty and you're talking about what the post-op plan is going to be for them, maybe you can put better plans in place to try to, optimize their outcomes afterwards. And I think specifically focusing on stress incontinence in men, we did a study using NSQIP looking at frailty and found that frailty is also associated with complications of AUS placement and removal procedures. And this was actually independent of age. So age was not a predictor, but frailty was. And so this is, again, a big driver of the surgeries that we're doing, but we're not necessarily assessing it. So in summary, to kind of think about this patient health and prognosis piece of things, I think that these types of assessments are really important because they can give us a more individualized context for our patients. They help us place decisions both for the patients and ourselves in a better understanding and provide a better individualized risk assessment. So we're able to think about these things like comorbidities, like life expectancy, functional status, which I didn't touch on, but ADLs are really important, and frailty. So next, we're going to talk about the benefits and harms of treatment. And this is something that, I think is well defined in our literature. We have, we know what the complication rates are. We are able to quote risk to patients. And so how can we improve our counseling when it comes to talking about benefits and harms? And what I would say is kind of two main things that we'll touch on. One is that we probably don't do this in a very patient-focused way. It's probably more surgeon-centric. And the other is that it's really not about weighing one choice versus another, but it's about considering many kind of shades of gray. And so these are complicated decisions that patients and us as surgeons are having to make when we're kind of weighing different treatment choices. So, how do we get to this patient-centric view of thinking about risks, complications, and even outcomes? And I think the key is really, what do patients want to know about making these treatment decisions? So we may know what we think is important when we're making these treatment decisions. When I go into a stress incontinence surgery, I'm really thinking about like, how dry can I get them? And, are they going to come back within 30 days with a complication? But what really matters to the patient is important. And Chris Seigel published a really nice qualitative paper on this, looking at, doing this type of work in prostate cancer. And I think this is a really good example of where it matters to go to the patient. And, when they did their analysis, they had some kind of a priori hypotheses of what would matter to patients. And many of those rang true. I think 5 of the things that they hypothesized, these are going to be important to patients when they're making decisions about prostate cancer treatment, were indeed important to patients. But there were a couple of things that they hadn't thought of that came up through discussions with patients. And those things are important to understand. And without talking to patients, you can't, get to those. So this is my plug for qualitative methodology. I think that we in general don't have a lot of experience with qualitative work, and so we shy away from it. But I do think it's a really important tool to use, especially when we're trying to understand the patient perspective. So, what is qualitative research? It basically allows us to gather and analyze data. We're really looking for an understanding of somebody's experience, their social reality, their attitudes, their beliefs, what's driving them. Typically, it involves focus interviews, focus groups, observations. And I think, again, really important if you want to understand, what's going on in somebody's life at a particular point where you want to understand what their experience is. So we set out to do this type of qualitative work in our stress incontinence patients. And we interviewed 36 men who had made treatment decisions for stress incontinence treatment. And we interviewed at least 10 people from each group, sling, sphincter, and people who didn't elect to proceed with surgery, and continued interviews until we reached saturation. And what does that mean? That basically means when you're analyzing the transcripts and finding themes, after a while, you find that you're just getting repetition of the same themes and you're not finding any new ones. So that's the point where you reach saturation. And we did these through conducting interviews. This was in the COVID days, so we pivoted to doing these via Zoom and recording them and transcribing them. And then we had 4 people who did coding of these transcripts. So all 4 individuals read these transcripts and had a code book that we used to do the coding. And this is what we found. So these were the kind of treatment attributes, if you will, that came out of that work. And, you know, everyone could probably guess that dryness is going to be on there, right? A lot of people, if you're getting treatment for stress incontinence, you care about how dry it's going to make you. But there are a lot of other things that were important too, and maybe some things that you might not have kind of thought about yourself about, you know, maybe some things that you don't necessarily counsel people about. And I think that the quotes here are actually really valuable because this is a time where you can really hear the patient voice. And even for dryness, you know, we may think of dryness as black or white, right? Like our studies look at dryness as an outcome. Are you dry or are you not? And for patients, that may not be the case. So, you know, this quote that we pulled out for dryness, he says, for what was going on, for what I wanted results for, I just wanted to be back to normality. I didn't mind if I leaked a little bit. I could live with that. So maybe it's not so much about being all dry or all wet, but it's okay if there's some improvement or some continued leakage, right? Simplicity of treatment ended up being another theme that came out. And this was kind of thinking about, you know, the complicated nature of having a device in, and a lot of people, for them, the device itself and the fact that it was complicated and that there were things that could go wrong with it was really a turnoff, and they did not want that in their body. The potential need for reintervention was really important. So people wanted to know, am I going to have to go back and have another surgery? You know, I think this quote, the principal thing in my mind was the surgeon said, these things do fail. Basically, what he suggested to me wasn't a single surgery where you could implant it and be done with it, right? So we know that this is important to patients when they're considering these treatment choices. Am I going to be back here in a few years for surgery again? One thing that was really important for a lot of people was this kind of concept of treatment regret or satisfaction. And, you know, we can talk about risks and benefits all we want, but in the end, what really matters to the patient is if they're going to be happy with it. And I think this quote is a good one to show that. He said, it seems obvious that someone would want to know what the chances are that this surgery will fail. What are the chances I'm going to need to get it redone? What are the risks of infection? If you list all those chances, I don't think that informs anybody about anything. I don't think it addresses the question, am I going to wish that I hadn't done this? Right. And this is the experience of when you know, I sometimes will, I always offer and sometimes put people in touch with others who have had this surgery done, because it's really that experience for people of saying, well, I kind of want to understand, like, is it worth going through this? Like, is this worth it for me? That's what I want to know. And then there's also a lot of people who had this kind of surgical avoidance concept. And I would say this actually came from various reasons. One is there are some people who just did not want surgery. They did not want it because they had a family member who had bad experience. They didn't want to go under anesthesia. There was some other reason. There were also a fair amount of people who had some complication or kind of trauma related to their prostatectomy. And so here they are in your office. You know, they feel like a prostatectomy has caused their leakage, and now here you are offering another surgery. Like, why would I want to do that? And so there are some people who really just, it doesn't matter what you can do to improve their quality of life. They don't want to go through another surgery because of the trauma that they have from that experience. So I think these are things that, you know, again, it's really important to go to the patient, to hear the patient voice and to understand what's important to them when you're, so that you actually know how to counsel people. So, you know, kind of in summary, as we talked about, our traditional endpoints, our usual kind of surgeon-defined outcomes, our risk-benefit discussions, those are really important, but they have to be tailored to the individual patient, and they have to focus on what patients want. We have to understand also that there are these kind of, you know, levels within risks. And so, you know, it's not black or white. There are these shades of gray that are important to talk about. For some people, those are, you know, they want to live in the shades of gray. They're not looking for, you know, a certain outcome. They might be looking for a different outcome, and that's really important to understand. Okay, so lastly, we're going to talk a little bit about values and preferences. And these, I think, are probably, this is the probably hardest part to think about, because these are so unique and individual, right? They're unique to each person. How do you actually understand these in the decision-making process? And by the way, you have a 15-minute visit, right? So this is something that has to, you know, you have to try to understand in a short period of time. And I think that, you know, we have to think about not just, these are important not just for surgeons to do good counseling, but it's also important for patients to actually make sure that they're making the decision that's really aligned with their own goals and values. So again, looking at our stress incontinence population, we asked people, okay, if you had to think about these various aspects of treatment, the likelihood of being completely dry, avoiding future surgery, not having a mechanical device, having a low complication rate, or having something that is effective immediately. What's the thing that's the most important to you and what's the least important to you? And I think what you see is, yes, a lot of people care about the dryness. That's not surprising, but that's not everybody's, first thing that they care about the most. And in fact, for some people, it's something that they care about actually much less on the spectrum. So, there's a lot of variability here in terms of what people care about. So we can't think of patients as one size fits all. And I think this is a nice kind of display also. We did this kind of small qualitative study. It was a mixed method study where we had a few kind of quantitative endpoints, and this shows on the bottom is their incontinence scores. ICIQ is an incontinence score. And then along the top is their level of bother. And you can see that, the blue is people who elected not to have surgery. The orange is people who had a sling, and the yellow is people who had a sphincter. And what I love about this is like the dots are all over the place, right? So you could have a lot of leakage and a lot of bother, and honestly, you could end up deciding anything. So these are very personal choices and very individualized. And so again, to say that, oh, the guy who comes in and he's leaking a ton, that doesn't necessarily mean he wants treatment. And we know this, there's a nice study from Matt Cooperberg that came out of the Capture database now many years ago that shows that, leakage is not the same for every person. You can leak 1 pad a day and be very unhappy, or you can be going through 3 diapers and the patient's like, yeah, it's fine. I can live with this. So, these are very personal kind of decisions. So how do we elicit these during the decision-making process? So this is my last little sidebar to talk about conjoint analysis, because I think this is a really interesting tool to think about understanding patients' perspectives. Conjoint analysis is a tool that's traditionally been used in market research. So it's been used by companies to look at customer preference. And over the last 10 years or so, it's been applied in the kind of medical or clinical setting in order to help understand the importance that patients place on various aspects of treatment. And it does a couple of things. One, it allows us to see as a whole in a group of patients, what do people care about? But it also allows individuals to actually assess for themselves, or, physicians to be able to understand what those preferences are. And this technique has been used in urology in a couple of places. In prostate cancer, there's a great example of it, and we've used it in urethral stricture disease as well. So I'm going to kind of talk a little bit about conjoint analysis using the urethral stricture disease model to tell you about it. So we looked at UCSF at a cohort of nearly 170 patients who had undergone evaluation for urethral stricture disease. And in conjoint analysis, what you do is you present patients with some hypothetical scenarios, and I'm going to show you some examples of those. And you basically say, okay, here's a bunch of different scenarios, and I'm going to force you to pick between the two. If you had to pick one of these, which one would you pick? And it gives them a series of scenarios. And through that process, you're basically trying to define to people, okay, what are they willing to give up for what gain? So what do they place the most importance on? What's less important to them? And, these options that they're given, they're not necessarily realistic, because what you're really trying to do is understand their underlying motivations. So here's some examples of what they look like. So you get these scenarios and you say, okay, if these were your only options, which would you choose? And you have to click a button. And so you have, the orange option on the left and the green option on the right. Along the left-hand side, you can see these are the treatment attributes that you're looking at. The extent of the procedure, meaning is it open or endoscopic in this case, the long-term success rates, the possibility of needing future procedures, how many, how long would the catheter stay in afterwards, how long would recovery be, and we threw in a cost question there because we were interested about cost. And so you're basically given these 2 choices, and you have to say, okay, if these were your only options, which one would you pick? And you're given a series of these. So, I put 2 of them up here, but they go through in this study, they went through 18 of them to pick which one would they pick. And what you get out is actually really interesting and I think informative results. So you use a mixed effects logistic regression to analyze conjoint analysis results. And what you find is that these are normalized to the success rate. In this case, success rate was really the most important thing to people. And you can see that it was nearly 2 times more important to people than anything else. And you can see how other things kind of fell out in terms of how they ranked in importance. So if you had to pick in the general, this whole population, one treatment attribute that was the most important, it would be success rate, right? Probably not surprising. And then you can see that other things like how long your catheters and probably is not as important to people. What you can also see is within these different treatment attributes, how do people think about the differences in the kind of levels of these attributes? And what I mean by that is, if you look at success rate, if you tell somebody, okay, you have a choice between, sorry, my slides are on auto advance for some reason. If you have a choice between, 85% versus 50%, there's a huge drop off in that. Whereas there's not a big difference between the 50% and the 25%. So there's a much smaller kind of difference in value that people place on that. If you look at the recovery time, you can see actually recovery time, those differences, immediate recovery, 6 weeks, 12 weeks actually doesn't make a big difference to people. So there's not a huge, amount of difference of weight that people place on these differences. Okay, also, we can look at subgroup analyses. And so these are really important when you say, okay, well, maybe there's a subgroup population who really thinks differently about these things. And so we were interested in looking at age in this case. And what we found was actually that older participants are more averse to this lower success rate, meaning, sorry about the auto advance. Hopefully this stops soon. So meaning older patients really said, I would much rather do something else to avoid that 25% success rate, that low success rate, whereas younger patients were more likely to, less averse to it. Similarly, for older patients, we saw a stronger aversion to more procedures. So, here's urethral stricture disease, where you may see a lot of people when they come in, these older patients, and we say, oh, they're really old, we're not going to put them through a urethroplasty, we're just going to dilate them. And, that may actually be really contrary to what you're seeing the data show, because in general, you're seeing the older patients actually want the one procedure that's going to give them the highest likelihood of success. So should we be doing these repeated dilations on these older men? Probably not. So it's something that can give you some really interesting information about these subgroups. We were also interested in looking at cost. And what we saw here was that for the lower income patients, the cost attribute actually ended up eclipsing or outweighing a lot of the other ones. So for the people who were kind of higher income, it really didn't play as much of a role. But for these lower income patients, it ended up being really important to them. And it weighed in more heavily into their treatment decisions. So then after we did this kind of conjoint analysis evaluation, we said, okay, well, did doing that exercise, did having patients go through this exercise of choosing between these hypothetical case scenarios, did it actually change something in terms of their decisions and their kind of decisional conflict? So we looked at decisional conflict using the SURE score, and there's many ways to look at decisional conflict, but this is an easy for question one. And we said, okay, we had them do the SURE score before they did the conjoint analysis, and we had them do it after. And we wanted to see what happened. And what we found was that actually there was a significant decrease in decisional conflict afterwards. So the actual process of doing this exercise helped them to understand and make these decisions. We asked them afterwards, you can see a vast majority said it was helpful in deciding what was important to them when they were making treatment decisions, and also helped them express their own priorities and treatment preferences. And we found actually the number needed to counsel to decrease decisional conflict or to get rid of it altogether was actually quite low. So this is really a quite effective way to help people in terms of making decisions that are aligned with their goals. So I think, the takeaways from conjoint analysis is it's a really unique and I think valuable tool that allows us to better understand how patients weigh their treatment options. And again, we can look at it in a more general sense. So we can see from conjoint analysis in general, what do patients care about when they're making treatment decisions, which may help us counsel the average patient. We can look at subgroups if we want to, like age or income, as we showed. And then you can also see how people individually place importance within those treatment attributes. So, how much does a success rate of, 80% versus 50% matter to people? And then we also showed that this discrete choice experiment actually improves the ability of people to make these decisions. So we saw that it decreased decisional conflict. And this is actually a tool, not just for us to help us inform, but it can also be a tool for the patient to help understand their treatment decisions. And this is important data, again, that not only patients can use to help them, but we can use in our counseling so that we're making treatment recommendations that are aligned. So in summary, we've talked a lot about this kind of model, this framework of how we get people to goal concordant decisions. And we've talked about patient health and prognosis, including thinking about comorbidity assessment, life expectancy assessment, and frailty. We've talked about the benefits and harms of treatment and how to make that more patient-focused or individualized. So how do we elicit those preferences or outcomes that patients really care about? And how do we find the nuances that patients want to be counseled about within those risk-benefit discussions? And then how do we really help people make these values-based choices? So, how do we understand for patients what treatment aspects they actually care about? And how do we help patients elicit their own preferences when it comes to making those decisions, in addition to helping, the surgeon who's counseling them? And all of these things together hopefully can kind of improve our goal concordant decision-making for patients. So I hope this has been kind of a interesting talk that hopefully applies to a wide variety of people. Here's some acknowledgements of a lot of people and funding that have helped me along the way in the process of doing this research. And some of this research started when I was, fourth year resident. So this is research that's been going on for a long time.